Good afternoon, friends. This talk is about EBOO, EBOO, which means extra corporeal blood oxygen ozonization. The blood is extracted from the body, goes into a special EBOO flask, oxygenated, ozonized, and retransfused. Ozone is a powerful agent and works against bacteria, virus, fungus, parasites. It is one of the most powerful detoxifying agent known to mankind and has effect at mitochondrial level by dual action of oxidation and antioxidation. Ozone is also used as EBOO by cinema stars, movie personalities and normal people for ethical biohacking, age reversal, aesthetics, performance enhancement and improved energy levels are also achieved by EBOO. Ozone is a powerful immune modulator acting at mitochondrial levels and has a very wide array of actions which are highly beneficial to the human body. Hematogenous administration of ozone can either be in small volume as in MAHT or large volume as in EBOO. We do not recommend renal filters and dialysis equipment for EBOO because IAOS does not believe that there is anything called ozone dialysis. Unlike conventional dosing, IAOS doses are high. They are very high but have been backed by clinical and laboratory tests for arriving at the safe dosage. Current recommended EBOO dosage is 250,000 to 350,000 micrograms per patient per session, translating to 250 to 350 milligrams. The indications and usage of the procedure is extensive. We have gone up to 450,000 milligrams in a single patient per session. From anti-aging in normal people to cancer regressions, numerous conditions have been reportedly treated very successfully with EBOO. This video shows the complete steps in real time, step by step in a unforwarded normal time video. The subject, not a patient, is an oncologist himself and a scientist who wanted to experience EBOO so that he could try the same on his patients. He holds patents in invention of mitochondrial organelle. He received a total dose of 400,000 micrograms or 400 milligram molecular ozone via EBOO in a 45-minute procedure. The surgeon first dons gloves. For every blood procedure, it is essential for our safety and for the patient safety that gloves are donned. 1 ml of 500 IU of heparin is drawn into a syringe and mixed with a 5 ml distilled water. The syringe is capped and kept aside as this is the first priming syringe. The total heparin used during each procedure will be about 8 to 12,000 international units. So, though 5,000 IU are drawn in this syringe, probably this amount will not be used in the patient. This 5 ml is now diluted with another, so this 5,000 international units or 1 ml of heparin is diluted with 5 ml of distilled water to make the first priming syringe. Once the syringe is full, it is capped and kept aside. The same steps are repeated to make the second priming syringe. 1 milliliter, 5,000 international units of heparin mixed with 5 milliliters or 4 to 5 milliliters of distilled water, extracted and the syringe capped and kept aside. These syringes will be attached to the donor and the recipient site venflons, and a very small amount of 1 to 2 milliliters of the same shall be pushed in to ensure that the blood doesn't clot in the venflon. So this is the second priming syringe. A normal saline bottle is now hung on a dip stand. This will be diluted with heparin so that the saline bottle continues to add the heparinized dilute saline. The remaining 3 ml of heparin from that vial, totaling 15,000 international units, is mixed with 500 ml of normal saline. It is better to hang a bottle on the stand, extract the remaining 3 ml of heparin in a syringe, push it from the back of the drip set bottle and allow it to dissolve in 500 ml of normal saline. The syringe is detached, leaving the needle in the bottle, which will subsequently act as an airway. So now we have a 500 ml of syringe with 500 ml of normal saline with 15,000 international units of heparin with an air vent in it. The next step is opening of the EBOO bottle and identifying the 3 markings on the top portion of the EBOO bottle. Here is the EBOO bottle. The top arrow and bottom arrow are shown separately. The top part is where the stainless steel filter is attached to the silicone stopper. The bottle is inserted into the hanger and checked that it passes freely and everything is in place. Then the top is opened and there are 3 markings: a small hole, a big hole and a plus. The small hole is for the entry of the heparin. The large hole is the entry of the blood set with the donor blood, and the plus mark is for the entry of ozone at 70 to 85 micrograms per milliliter. Now the ozone donor set is opened. It is ethylene oxide 100% ozone compatible silicone based transfusion set. Once the inner packing is opened, the set is uncoiled and the parts are identified. You can see that there is one inflow which is a silicone part with a lure lock. Then this inflow joins a 3-way into which there is a bulb with will be pushed into the heparin. The blood set bulb is inserted into the large circle while a bent needle is inserted into the small circle. I have handed over the lower lock portion which goes to the donor to the nurse. The small bulb without a flask is pushed into the heparin bottle, that is the saline bottle, plastic saline bottle with the heparin 3 ml, that is 15,000 units mixed with it. So the bulb without the filter is inserted into the heparinized saline bottle already hung on the stand. So here this is a three-way, and this three-way connects to the patient inflow system. So we have pushed the heparin bottle, the bulb without the filter into the heparin bottle, primed the transfusion set, opened the transfusion set and allowed this heparinized saline to flow into the entire set so that the whole set is primed. This priming or coating of the interior of the set with heparinized saline solution will ensure that there is no clotting in the set. Next, we open the bulb with a filter on it and the bulb with a transfusion filter. This has to go into the larger circle of the borosilicate EBOO bottle with silicone stoppers. IAOS system is the first in the world to have pure silicone and glass material instead of the cellulose renal filters commonly used. Next, a 16 gauge needle is pushed into the smaller hole which will be for the waste. The next picture shows the top of the EBOO bottle with the three markings: a big circle for the blood in, small circle for the heparinized saline in, and the plus mark for ozone bubbling. So the top part has the SS diffuser attached to it, the bottom part is for exit only. These are clearly marked on the bottle and one has to be very careful about that. Now we check the needle, bend it to 90 degrees, attach it to a silicone bottle, a silicone tubing, and this is pushed into the top of the bottle through the small circle. This will extract the waste or the bubbling froth from the patient. So now we have inserted the blood set, heparin part and the waste to the top, and we are ready to locate the vein, donor vein, and attach it to the system which can be put into the perfusion pump. It is very important to ensure that the patient has good thick veins before attempting an EBOO procedure. If you do not have at least 18 gauge veins, the procedure will take too long and there is a possibility of the venflon getting kinked. The perfusion pump is now switched on and tested. Another needle is bent to 90 degrees and that is connected, pushed into the plus of the top of the bottle and is connected to the ozone out machine. So now we have a waste out, an ozone in and a blood in and a heparinized saline in. Now the entire system is ready and the nurse can start with locating the donor vein, identify it and put in a venflon. Thankfully, the subject here has very good veins and so we can put in a 16 gauge IV cannula which will make the procedure extremely easy with lot of spirit or sanitizer the arm is cleaned, the bulging veins are identified, and a cannula is gently inserted. In case we are using larger cannulas, it is better to use little local anesthetic in the skin superficially to make it less painful while the cannula is being inserted. Insert the thickest Venflon cannula that the vein can accommodate, because better the outflow, more the blood will flow into the flask and better will be our inflow. The nurse here is now infiltrating the superficial part of the skin with xylocaine to ensure that the Venflon insertion is not painful. For injecting the local, it is essential to use a 26 gauge needle or an insulin needle, so that the Venflon insertion is extremely pain free and the patient is comfortable while it is being injected. We need skilled hands. I am fortunate to have a nurse who is very good in finding the veins. If it is very difficult for the nurse to find the vein, I prefer to do the Venflon insertion myself. Once the vein is located and the Venflon is inserted, the priming syringe is attached and left in situ while the Venflon is anchored. Again, emphasize that narrower than 16 J narrower than 18 gauge will not work comfortably and are best avoided. Once again, the perfusion pump is checked and we have to ensure that the direction is in such a way that the blood is sucked from the donor site and goes into the bottle. We cannot afford to have a machine running in reverse. The lower end is attached to the patient, but before that, the special silicone part after the bivalve attached to the heparin is now put into the machine after checking the direction. So, we now want to move the machine in such a way that the blood is sucked from the patient to the bottle. This is demonstrating the directional change with the IAOS EBOO perfusion system. The silicone part is inserted into the machine and the machine is locked in place. Only after this we connect the pipe to the donor side. The most important step is that the silicone portion before the T connection to the heparin solution should not be put into the perfusion pump. Only the silicone portion after the three-way or bivalve connecting to the heparin should be inserted into the perfusion pump. Now, the lower connector is locked to the Venflon, and once the connections are tight and the tubings are loose, we can switch on the machine. At this stage, we cut down the heparin to a very low level and we switch on the perfusion pump at a very low speed. It is best to use a starting speed of about 5 to 6 ml per minute, and once the blood flow has established itself, we can increase the speed. The perfusion pump has been started, and very slowly blood from the patient's vein is being extracted into the pipe, which is gradually moving towards the perfusion pump. If we suddenly increase the speed or keep the speed at 30 to 40 ml per minute, despite the thick venflon, the pressure will kink the tip of the venflon and the blood flow will stop. We now adjust the regulator to the precise concentration and ensure that ozone flows into the bottle so that the bottle is ozone primed even before the blood reaches the bottle. We can see the dark color of the venous blood and the very slow flow rate. Once the flow is established and about 1.5 to 2 feet of the tube are filled with blood, and as the blood is approaching the heparin bivalve, we can increase the speed to 25 or 30. This stage, we reduce the speed of heparin and allow a very slow mix of heparin with the blood. The blood, venous blood, slowly starts dripping into the EBOO glass bottle set, which is already primed both with heparin and ozone. We must remember that the blood flows from the top and it comes out from the bottom. The recipient site, while the blood is filling the bottle, we must locate the recipient site and insert the venflon. Donor site has to be always in the cubital fossa and the tourniquet remains in position for the entire duration of the procedure. Recipient site can as well be in the wrist, and a thinner venflon, which is 18 gauge, can be used. Here we have used 16G for the donor site, and we will use a smaller 18G needle for the recipient site, and we will see if it is possible to get a distal vein over the wrist area, which is more comfortable for transfusion. We must again emphasize that the wrist area is not a good donor area because it produces wrist cramps and hand cramps, and we cannot apply a good tourniquet on the forearm. So, donor site has to be invariably the elbow, while the recipient site can be the wrist. So, a green venflon or an 18G venflon is inserted into the recipient site. The subject is made to wear the ultraviolet protective goggles. The priming syringe is attached, and the recipient venflon is now strapped in place with the appropriate sticking plaster. The ultraviolet light is switched on and the blood gets irradiated and bubbled with ozone. We have not yet started retransfusing the blood. The primed syringe attached to the recipient site stays in position. Always start suction at 5 ml per minute, and once the blood starts dripping into the flask, increase the speed slowly. 30 to 40 ml per minute is the maximum speed recommended if the tubes begin pulsating, reduce the speed. The tubes must not pulsate. We wait until 50% of the flask is filled and is continuously ozonized. Only after half the flask is filled, the bottom stopper is opened and the outflow set is pushed into the bottom of the bottle. We can see that the outflow is now pushed into the bottom of the bottle. We clamp the blood set when we push it into the large circle in the bottom of the EBOO bottle. A stainless steel cup is kept for catching the excess flow. The bulb is primed, the flow is started, and once the air from set is removed, the recipient site is attached to the other elbow. Both connectors are lower lock and airtight. We have primed the set and we are opening the blood flow. Once it reaches the other end and the air has been emptied, the set is closed. We can see how bright and arterial the blood looks. With the UV light switched on, extra antibacterial protection, anti-detoxifying effect along with the ozone effect is achieved. We remove the priming syringe and attach the recipient site to the patient's other vein, and the blood flow has to be adjusted to exactly match the inflow to ensure that there is a consistent and uniform ozonization and the extracorporeal blood oxygen ozonization happens properly. We are now using a 1/16th of a liter flow ozone, which will produce close to 110 gamma, and the inflow and outflow are evenly matched. At this moment, 40 ml per minute of blood is being extracted. We can see the color difference between the inflow and outflow without the use of a renal filter. Very essential that this is a pure borosilicate silicon inflow outflow system which is completely plastic free and does not use any filters, especially the cellulose tri-state filters, which are not recommended by IAOS. The ozone flow and pump rates are constantly titrated and this is patient dependent. The foamy waste exits through the small hole on the top stopper and the silicone and the discharge is the spent gases into the glass bottle. We can see the speed of oxygen is 1/16th of a liter and sometimes it is increased to 1/8th of a liter. We titrate the inflow and increase or decrease the speed of the perfusion pump. At the same time, we also increase or decrease the concentration of ozone, all the time assuring that the ozonization is perfect. We can see the color difference, we can see the froth and the waste coming into the bottle in the bottom of the tray. So, one pipe is for ozone in, one pipe is for blood in, one pipe is for heparin in, one pipe is for the froth out. As the IAOS system practically absorbs all the ozone that is administered, there is no need for an ozone destroyer at the outflow or exit site, and the outflow can be directly put into a bottle. Here is the inflow and outflow, not of this patient but from previous patient, which shows that 102 milligram per ml ozone in the inflow, whereas 6.47 gamma in the exit tube. So, this is the comparison of the inflow and outflow of ozone, meaning that close to 95 milligram per ml is absorbed by the blood. The dose calculation is extremely simple. 1 by 8 liter per minute of oxygen at switch 4 produces 85 gamma or 85 microgram per ml input, which in 1 liter will become 85,000 micrograms per ml, 85,000 micrograms. The same perfusion continued for 32 minutes will be 340 milligram, and in this patient the procedure was run for a duration of 40 minutes and the total dose administered was 400 milligrams or 400,000 micrograms. The patient was extremely comfortable throughout the procedure. Once the desired dose is administered, the donor site is detached and all blood in the donor tube is allowed to flow in the EBOO chamber. So, we are now removing the paper tape which had kept the silicone tube in place. The venflon is detached from the donor site and held high while the perfusion pump is allowed to continue and pump all the remaining blood into the system. At this stage, we can increase the speed of the pump to as much as we desire because it is no longer connected to the vein. So, here I am increasing the speed of the perfusion pump and allowing the blood to move in rapidly, and the whole blood is being emptied into the top of the bottle. We control the outflow and ensure that too rapid an inflow is avoided. However, as it is a patient's own blood, the inflow speed does not matter. Once the blood is emptied from the top of the bottle, the bulb is removed and also the heparin saline bottle and all the tubings which were used for ozonization is removed and discarded. The tube needs to be removed from the perfusion pump before the used tubings can be discarded. Ozone continues to flow and bubble into the blood, and the waste also remains attached to the top of the bottle, and the whole system continues to ozonize the blood until the bottle is empty. We can see the highly oxygen and ozone enriched blood which is tomato red and flowing into the patient. The waste outflow is retained in place and this is the waste part where the bubbles or foamy frothy material is coming out. Less than 10 ml of actual blood is there in the froth. Once all blood from the bottle has flown out, the set is pulled out and the remaining ozonized blood is allowed to flow into the patient's body. So, from the bottom, the transfusion set is removed, the blood is allowed to gradually flow and it is now emptying into the patient. The entire blood that has been withdrawn has gone back into the subject. The subject here, oncologist himself, is feeling extremely comfortable during the entire procedure and has been observing it carefully because he intends to use this procedure on his patients and wants to try it on himself before he attempts it on his patients. You can see that the ozone compatible tubings hardly retain any blood on their surfaces. The recipient Venflon site is now capped and the ultraviolet lights are switched off. So the tube is detached and Venflon is capped. Later, both the tubings can be removed, padded and sealed. You can see this is the EBOO flask and this has no ozone residue. If you want to learn more about this unique IAOS EBOO system, feel free to message me in the above number in WhatsApp. Thank you very much. Thank you.